Greetings, Don Rucker. I'm the Chief Strategy Officer at Up Health and former National Coordinator for Health IT in the United States, and wanted to talk today, so we're talking now August 2025, about some of the recent quite amazing policy updates in Washington, D.C. As I think this audience knows, all kinds of things have been going on in Washington, and we've put this into a slide deck as well for folks. But really the big news is the new administration is really doubling down on digital in healthcare, and we'll explore what that means. This is, I think, frankly, a change from the first Trump administration where I worked, where we put out the Cures rule, but didn't have the broad support that is occurring in this administration. So you may have heard about the White House event on modern health tech, digital health tech. There have been multiple CMS and ONC events about this. You've heard from Secretary Kennedy, Administrator of CMS, Mehmet Oz, and a number of other folks who are major players in this. Chris Klump, the head of Medicare, Tom Keene, the current national coordinator, now renamed Assistant Secretary for Technology Policy in the DC naming game, as well as some of the key figures at CMS and ONC, including Amy Gleason, Arta Kara, and Steve Posnack. So what have these folks all been up to? What is really going on here? I think there are a couple things to double down, but before we get into all of that, as exciting as the digital is, it's still worth understanding in the vast spending of CMS what the main economic issues are, because they haven't gone away in the new administration. Now, the politics that you've probably heard about, for the most part, are really about Medicaid and who's eligible for Medicaid. But the big flagship Medicare Advantage and classic fee-for-service programs also have a number of sort of pressing political issues. Medicare Advantage, MedPAC, so the Congressional Oversight Agency, says is last summer said it was 22% overpaid. Now that's an interesting political dynamic that's going to come up against the historic GOP desire to support Medicare Advantage more thoroughly. So we'll see how that plays out. Very interesting. On fee-for-service, so the classic Medicaid, probably the big news is there's a move to digital, maybe AI included, prior authorization, this program called WISER. WISER is a program that started about 15 years ago, looking at the appropriateness of various medical services. CMS, really for the first time, is doubling down on prior auth in classic Medicare. Historically, it's only been for things like durable medical equipment. A couple other big areas: program integrity. You heard Dr. Oz say that they want to audit every Medicare Advantage plan. We'll see how that actually plays out. They are trying to pivot, which is very digital in its own way, to catching fraud before they pay the money rather than the pay and chase model that has historically been there. So I think you're going to see a number of changes in that. Another big change is the emphasis on prior authorization. Secretary Kennedy led an event where over 50 payers said they were going to improve prior authorization. So less procedures put into prior auth, more digital. Very, very interesting. Big emphasis on that. So when you look at the big picture of digital here, there are two big themes that were clarified at the White House event, though they've been in place and before the last couple months. And I think the thing to think about here is there are a lot of folks from the venture capital and artificial intelligence communities in the new administration. So it's not a surprise that they look at Medicare and Medicaid and CMS and healthcare in general and find it wanting. The two big areas that have been the focus. One is what you can call digital enablement. And what does that mean? We'll get into that. And then the other, which is very related, are these CMS affiliated networks. So what are some of the arguable backbones for interoperability? The core part on digital enablement are two pieces. And when we talk about digital enablement, we're talking about the digital app economy. How do you get healthcare onto your smartphone? The two key pieces are what are called IAL2 and AAL2 services. So these are authorization and authentication services. So you know who you are. You've already used this on your daily lives in bank or brokerage accounts or every high importance type of activity, getting on an airplane. Social Security, even vast scale, uses these types of authentication. What this allows folks to do is the folks who have the information, the providers, are now going to be in a much more secure position to release that because they're going to know exactly who that patient is. So many of the arguments have historically been made about, oh, we can't release information because we're protecting privacy. Those arguments really, I think you're going to find are vanishing. The other big area is a national provider directory. So a national provider directory is much like what the modern internet has with domain name services, DNS servers. So it will allow everyone to find the endpoint. So where the providers are, where the payers are. The patient endpoint, of course, is their cell phone number, and their email address. So this is quite exciting, a huge firmament for that. And you're going to see in policy from ONC, I'm pretty sure that there's going to be a shift from regulating the EHR functions to regulating performance of the APIs. So service level agreements here is going to be very important. The other big area are these CMS affiliated networks. Historically, we've had Commonwealth, Care Equality, eHealth Exchange, some of those networks. Obviously, TEFCA has been an effort to do various things here that's had many, many deep fundamental security challenges and privacy challenges, as well as huge cost issues with the brokerage model for doing this and the antiquated technology. CMS is saying we really don't want to go there. So how that all plays out, I think, is to be determined. What are the technical standards there? But overall, I think you're going to see more RESTful APIs, more modern APIs, and FHIR was a theme throughout all of this. CMS announced at the White House event a couple of very specific things that they're going to do. And at the risk of missing one, I'm just going to read this responsive reading, apologies, in their order. One, an enhanced plan finder. So Medicare patients, Medicare Advantage patients are going to have it easier to find the plans, compare the plans. We talked about the National Provider Directory. This is FHIR-based, so very computable for modern apps. We talked about modern identity. They're going to start with Medicare.gov. And in a related note, a faster blue button, which is Medicare's digital app enablement with FHIR-based digital insurance cards. So that will really be something, frankly, for all payers. This is being wrapped up in data at the point of care and, again, relies on digital identity, the National Provider Directory, validation here. Once you're authenticated in the National Provider Directory, then sharing clinical information under the HIPAA treatment things becomes a much more automatic thing because there's no question of who the provider is who's taking responsibility here. This goes back to the old, I think, New Yorker cartoon from 20, 30 years ago on the internet. Nobody knows if you're a dog. Well, security is a huge issue. Privacy is a huge issue. These identifiers allow you to do that. And then finally, what they're calling trusted exchange, but not trusted exchange framework, and CMS-aligned networks. So those are the specific policies that are out there that I think you're going to see digitally. Payers are going to need a lot more clinical information to allocate care, whether that is to how you design your network, risk management, case management, obviously prior auth, quality measurement, which is still a work in progress, I think, in what the new administration wants to do. So broadly spoken, a lot more clinical information is going to come in. Historically, most of our payments have really been done purely off the clearinghouse X12 revenue cycle pipeline. But what you're going to see is that is going to change materially with the need for clinical information so that we can maintain sanity. The prior auth work is really the first part of this, but prior auth is really just the starting point in this clinical information. So how are you going to get that clinical information is, I think, the next obvious step and has always been the hurdle. I can tell you from personal conversations, the new administration is highly aware of the issues with EHRs not opening up to get this information out. You saw at the White House event, they got all the major EHR vendors to sign that they were going to agree to this. Now, how much of that is going to be voluntary and how much of it's going to be voluntold and how much of it's going to be enforcement action through information blocking, all of that is to be determined. I think you're going to see each of those three things getting you the information out. Bulk fire was mentioned. So bulk fire is it was really designed, we designed it for payers to have some ability to compare providers on a scale, on a broad national scale, with a lot of accurate data. Always as a provider, my patients are sicker than those other patients, so you need to pay me more. Well, with bulk fire, some of that will, I think, change. You're going to see work on just performance of bulk fire. There's been a lot of attention to that. You're going to see work on some of the queries there, but that will all come. An interesting question is really that with the emphasis on AI, the Cures Act in 2016 actually required all data to be made available. Now, when we wrote the Cures Act, the first rulemaking on that in 2020, the large language model revolution hadn't really hit yet, the ChatGPT and everything else. Now, there's a lot more interest in all data. Now, all data is not structured data. It's not data that necessarily you can, immediately put into an app as is, but it is the fuel for artificial intelligence, any number of things, which include, for example, prior auth, prediction of health, more refined adjustment to what should be done next in a patient's care, many, many interesting things with AI, in addition to some of the current AI uses on imaging and molecular genetics. So you're going to see an emphasis on all data. That will be a AI-driven thing. So this brings up an interesting question, which obviously, is something we've been working on at OneUp, which is how do we get all of this data that's coming in? How do we make sense of that? How do we organize that? You're going to have to put this. This is not just something you're going to stuff into your enterprise data warehouse where you may have put snippets of prior auth data. It's going to be a much richer world when you have these large amounts, often in fire, of clinical data you're going to need to do real-time compute on and real-time event processing. So these are interesting conversations. We're excited. We think we have the platform for that. But you're going to see way more clinical data, and you're going to see that data, including event processing, real time, as the foundation for digital apps and a bigger digital economy in healthcare. They're very interesting times, and we look forward to answering any questions you may have on any of these things. You can reach out to me at don@oneup.health. Take care. Thanks.